introduction of balloon in LA. Again, the above 4 steps would be shown to you practically by my colleague. Again, I'll focus on issues and tricks of crossing the mitral valve, and would be few points discussing the balloon dilatation. After balloon dilatation, we normally remove balloon and wire from LA and post-procedure care of the puncture site. Again, these 2 steps would be explained by my colleague during a case presentation. So, to start with, I think you all are aware that this PTMC, we do pre-PTMC echo score, and Wilkins score is the most common score people do these days. And everyone knows that from echocardiography department, there comes a report saying, okay, this is the Wilkins score. And we know that 8 is a good score, 9, yes, and we can go to 10. But when we are going for PTMC, we should also keep in mind certain things from the interventionist point of view. First of all, if there is a calcification, suppose the score is 8, but the subvalvular disease is slightly less as compared to the calcification, then we should keep in mind that inflations at relatively low pressure is recommended. If the echocardiographic report or the echocardiographic patient shown that the subvalvular disease is more, then we try to use the balloon of slightly lower size. And if the valvular thickening is more as compared to calcification and subvalvular disease, we would have to use inflation at slightly higher pressure to go for ideal procedure. Again, there's a commissional score, and everyone aware that we go for commissional Wilkins score and calcification score. This score is also very important and very helpful in detecting the success, and also in anticipating few of the complications that can occur in during PTMC. Again, with this Wilkins score, there should be few consideration from the interventionist point of view, which we should take care in the cath lab. Like with more fusion and calcification, the chances of unsuccessful procedure and also chances of post-procedure MR increases. It's safe to use slightly low size balloon and low inflation. Coming on to the few points regarding the anatomy of atrial septum. Well, actually, I would like to highlight that as you can see from this aortic, posterior aortic wall, that septum is the continuation of the aortic wall downwards. Okay, and below this septum, and we can see.
You have, excuse me, sorry to interrupt. आपकी आवाज echo बहुत कर रही है for some reason. If you can, if everyone can shut off their microphones while he's giving a talk, that'll be great. Or
okay, let me check it.
आसपास से किसी ने फोन वगैरह ऑन किया हुआ है टॉक का, तो जो भी है वो ऑफ कर दे ताकि echo ना करे.
I think ये आपका जो है ना जो editor है जो control कर, he will be able to sort this out. There's some echo going at the speaker end. बाकी के साथ echo नहीं हो पाता.
जी, I can hear your voice very clearly. तो आपके मेरे ख्याल से आपके end पे ही थोड़ा होगा. चलें शुरू कर दें talk में.
Okay, is it okay now? What about now?
It's better now. Yes, it's better.
Okay, okay. So we are talking about this anatomy of the septum. So as I told you that this is a continuation of aortic wall, and one should be very much careful regarding the position and the presence of the aorta in the upper part of the interatrial septum. Again, the superior vena cava and inferior vena cava, the relation of superior vena cava and inferior vena cava and the septum should be very much in mind. Okay. What is the objective of this atrial transseptal puncture? It is basically the safe and effective delivery of catheterization equipment from right atrium into the left heart. Okay, the method of transseptal puncture in our discussion, I mean, our discussion will be focusing on Inay's method with modifications of Hung's method. As I told earlier that there are 3 methods currently in use. People do it from the different ways, but our focus and our training would be on the Inay's method and Hung's method. There are a few landmarks required for the septal puncture. First of all, because we are doing it angiographically, we need to identify right coronary sinus and the upper end of the tricuspid valve. Then there is a vertical midline, then is the horizontal M line and puncture point, which is the puncture P point. I am very much sure that you would be able to see the two pictures here. The first is the schematic diagram, and other is the angiographic diagram. And in this schematic diagram, as you could see from the pigtail, that when we place the pigtail in the right coronary sinus, it is basically the upper part of the tricuspid valve. And it is very much clear from the angiography as well. Keeping in mind in this point that our pigtail in the right coronary sinus marking the upper point of the tricuspid valve. Second, we come to horizontal M line. Another important step to go mark the landmark for this horizontal M line is to do an LV angiogram in RA view using the pigtail ideally. And during one thing we have to tell the tech basically to focus or to keep in mind the spine as well, the vertebral spine, because we need to landmark to keep in mind the vertebra. After angiogram, we'll mark the LVOT, and then from the center of this LVOT, we'll mark a horizontal line, which is basically the horizontal M line. As it is done in the RO view, we'll keep in mind the vertebra it is crossing. It's very much clear. The last rib attaching to the vertebra is T10 vertebra. So we have from this RO view, we have seen that the horizontal M line in relation to the T10 vertebra, as in the right side of this picture, you could see that it is crossing lower border from the T9 vertebra. Now coming on the left side, as we can see that we have marked a horizontal M line crossing the upper border of the lower border of T9 vertebra. This is done in RO view. Then this is a vertical midline, which we normally do in AP view, frontal view. From the base of the pigtail, we mark and again another imaginary line coming towards the most lateral border of the heart. Normally, in normal situation, this lateral border of the heart is formed by the LA, but in mitral stenosis, it is understandable. It is assumed that it is the most lateral border of the LA. From the center of this midline, we mark an imaginary line, which is the vertical midline, and it is basically the location of interatrial septum. We have to do it in this way because with dilatation of LA, in the presence of the structural heart disease, the anatomy is totally distorted. So we cannot take the fixed structures as it normally with the heart according to the vertebra or according to the fixed landmarks. So we take a vertical M line. Now, keeping in mind our horizontal M line, which we have done in RA view, we'll see that at what point it is transecting the vertical midline. This vertical midline transection of the horizontal M line is basically the puncture P point. It is very important that at times when we train our resident, they say that you have done it in RA view and now you are coming down from the SVC in the frontal view. So how we could see? This is the point, as I told earlier, that we have taken in mind the vertebra T10. So in our mind, in our imaginary line, that it is transecting the spine at the lower border of T9, and we'll see at what point this vertical midline is being transected by the horizontal M line, which is basically the puncture P point, which is ideally or imaginarily the point of the fossa embolic, fossa vallis. We have to keep our puncture within 2 to 3 centimeter radius of this puncture P point. Now, just a few points regarding the catheters and instruments needed. For transseptal puncture, there are 3 instruments. Number 1, there is a Mullins sheath, again, Mullins dilator, and then a puncture needle. Normally, we don't use sheath here in transseptal puncture. For PTMC, we go for the Mullins dilator and the puncture needle. I would just like to mention the steps. First of all, we assess the left. Again, these steps would be will be told in detail by my colleague after the case presentation. But just to go across it, there is accessing the left innominate vein by using multi-purpose catheter. Exchanging the wire, we will remove the multi-purpose catheter and place the wire in the innominate vein. Then Mullins sheath or dilator on the wire in the innominate vein. Introducing puncture needle there. Already our pigtail in the right coronary sinus, marking the upper border of tricuspid valve. And from there, we will descend our puncture needle along with the dilator to the fossa ovalis region, to this region. angiographically in the frontal view, and keeping in mind the point where of the spine where this horizontal M line was transecting the vertical midline.
Can you use a pointer over here? The audience were requesting when you would especially
Right.
use a pointer.
Let me check it from where I can take out my pointer.
Yeah. We can see it now. Yeah.
Okay. Can you able to see the point on the slide now?
Yeah, we can.
All right. Okay. So from this horizontal M line, it is transecting the vertical midline. Okay. This horizontal M line was taken in RA view, and vertical midline, which we are normally coming down from the in AP view. So in relation to this T10 vertebra, we have marked our point of transection of horizontal M and vertical midline as a puncture P point. Okay, I have already told about the instruments and now the steps. Okay, while coming down from the AP view, from the innominate vein, we have to keep in mind the needle orientation. So according to the size of LA, if it is, and the needle orientation, again, when we show you the instruments, we'll tell you how the needle orientation according to our landmarks. So in normal LA size, like 4 to 5 centimeter, normal LA size, it is 4 to 5 o'clock position. If the LA is moderately large, we'll keep our needle in 5 o'clock position, and it's significantly large, we'll keep our position in 6 o'clock position. The larger the LA, the more it becomes horizontal. So we'll rotate our needle according to the size of the LA. Again, identifying puncture P point while coming down. Shaw et al. Described the staircase movement. Well, from the left side of this picture, it is, as you can see, that when we come from SVC, when we come down from SVC, there is a dip. First of the dip was from SVC to RA, and the second dip is from aorta. The third dip basically is the limbic puncture and is the fossa vallis, limbic region of the fossa vallis. So this is Shaw et al. Which has described the staircase movement or step down movement from this. As we are coming down from innominate vein in AP view. So I have shown you how from the T10 vertebra we will mark our puncture P point in relation to the transection point of horizontal M and vertical midline. Now there are two confirming points. Few people do an RA view, few people do in LA view. But now the most common view, what we practically use is we go in the left lateral view. And in the left lateral view, by staining the septum with a dye, we see a curvilinear-like portion marking the septum. We tent the septum by slightly raising the dilator and the puncture needle. And after that, we'll do the puncture, the staining like this. In the left lateral position, we have there are 2 points we would like to keep in our mind. First, that our puncture needle would be in the center of this right coronary sinus pigtail catheter. We have placed the pigtail catheter and the spine. After doing this puncture, we take out the needle, and from the dilator we can do an LA gram, confirming our this dilator in the LA. We'll put our pigtail LA wire in the LA, and we take our dilator out. We take the LA pressure here as well. There are 2 points I would like to mention regarding the balloon sizing. Selection of the balloon is normally done by a simple equation, which is height in centimeter divided by 10 plus 10. but the relationship of one's height to the diameter of mitral valve orifice is not necessarily linear. There are a few changes. And secondly, annular calcification will also affect the mitral valve orifice regardless of patient physical build-up or constitution. So most of the people use this simple equation, which is height in centimeter divided by 10 plus 10. Now in PCR textbook, there is another selection of balloon size. They have standardized the selection of balloon size. Like if the height is more than 180 centimeter, they take the balloon of 30, and they keep in mind the inflation, the staged inflation from 26 to 30. If the height is from 160 to 180, they take a balloon of 28. And now they do the stages inflation of from 24 to 28. And if it is from 147 to 160, they take a balloon of 26 and they do the inflations from 22 to 26. Any height less than 147, they take the balloon of 24 and they go for stage inflation from 20 to 24. This is the NOI balloon we take. I'm very much hopeful that everyone who has done the rotation in the cath lab, especially in Pakistan, would be aware of this NOI balloon. There are two important slots. Number one, the main stalk and the vent stalk. I would like to mention the very important step here, that this balloon, basically there are the three parts of this balloon. It is a single balloon, but there are three parts. When we start our inflation, first the distal part of the balloon, this is inflated. When we continue inflating it, then the second part of the balloon, the proximal part is inflated. And
please use the pointer if you can when you're talking.
All right. Just let me do that, okay. Okay. So first of all, the most distal part of the balloon is inflated. When we continue inflating, the second part of the balloon is inflated. Okay. After that, if we further continue in our third stage, then this part of the balloon, which is the hardest part and which is the part which is basically designed to balloon the mitral valve, is inflated in the last. So, and this is very important during our balloon, when we take out, when we are taking out of the balloon, we are positioning the balloon from the LV to the aortic valve, to the mitral valve, because after the inflation of the most distal part, we start pulling it out towards the mitral valve. When it got fixed in the mitral valve from the LV, then we inflate the second balloon. And when the second balloon is inflated, we stop our pressure, our pulling pressure on the balloon. Otherwise, it will come out. So we have to stop our pulling pressure. And then during this continuous inflation, this third part of the balloon is inflated, which is actually the ballooning the mitral valve. Coming on to my next slide. Sorry. Okay. So again, I don't know, there's some mark, and anyhow, I have already discussed this selection of the balloon size. Okay. One important point that in the LA, the inner gold hub, and now during our case presentation, we'll show you the three parts of the balloon during the preparation, the inner gold hub and the outer silver and the straightener, and how they are removed. Just when we are entering, and first when we are in LA, the inner gold hub and then the outer silver hub is removed, and during the taking out, and then the LA wire is removed. But practically this would be explained during our case presentation. I just like to mention few steps regarding the balloon crossing when it is done in RO view. This 4 points would be very helpful in our successful crossing of the balloon. First of all, the LA angiogram, which we have done in locating the mitral valve. This will help our positioning of assessing the position of the mitral valve. Second, the bobbing or the movements of the balloon when it will face the mitral valve. There are few forward movements towards the LV apex, which is normally called as the bobbing of the movement. And falling of aortic pressure, this is very important, which indicates that balloon is now obstructing the mitral valve. The fall in the aortic pressure and this obstruction of this mitral valve, definitely there is a fall of the aortic pressure after that. And when we are in LV or we are entering the LV, there are ventricular ectopics, shows that we are now entering into the this LV from the mitral valve. So these 4 points, they are important. They show are successful in crossing the balloon, which is normally done in RO view. So this, I would like to show you a small, short video. This is the bobbing of the this mitral, this balloon, annoy balloon. And it is these are the movements when it is facing the mitral valve. This bobbing movement indicates that now the balloon is in front of the mitral valve. Again, the crossing of the mitral valve, it depends on the size of LA and site of puncture. If the size of LA is large, again very large, then there is some difficulty due to the short appearance, relatively appearance of shortening of the balloon and site of puncture as well. Whether it is too high or low, it will also affect. As I have shown you here, there are 2 slides. On the right side, there is a slide. Okay, so as I told you that this, from the base of this pigtail catheter which is placed, this is the line we have marked as horizontal M line, which is ideal, and it is marking the upper border, level of the upper border of tricuspid valve. Now, if the puncture is within 2 to 3 centimeter radius of this, it is a good puncture. Now, this puncture is slightly low at this level. If the puncture is at this level, it is a low. The stylus, which we normally put in the balloon, which is helpful in crossing, if we increase the angle, this is the normal shape of the stylet. If we increase the angle of this and further angulate it, it would be helpful in crossing the mitral valve. On the other hand, if the pressure is high, if we increase this angle as well as this one, if we increase this angle, it will give appearance of lengthening of the balloon, and it will be helpful in crossing the mitral valve in case of high pressure, high puncture, sorry. At times there is significantly dilated LA, and people do use reverse loop entry, which I have shown in the picture. And this reversing is done with the help of the this pigtail LA wire. We have to recross again from the dilator the LA wire, and we have to make it reverse and then do the balloon. It is helpful in case of the significantly dilated LA. At times in the there is significantly stenosed mitral valve, and we are unable to cross the mitral valve. Then over the wire crossing using 035 wire is very helpful. We can cross the balloon with the help of this this wire. After the balloon in the LV, so these are the stages I have mentioned here. Again, I would like to further highlight it. Like, this is the first stage. Okay, through this first stage, we start pulling the balloon out. In this stage, the balloon is now fixed across the mitral valve. After that, we'll not pull the balloon out. And this is the third inflation. After this inflation, this is at this point when the mitral valve is actually dilated with this inflation. So this is the very important, because most of the time people say that we have taken out the inflated balloon. It is because that at this point we continue pulling the balloon out. Actually, the mitral valve is not dilated. We have maintained our pressure pulling out, and it has come out without the further dilatation of this part of, which is basically used to dilate the mitral valve. The procedural success, I am very much hopeful that you all would be aware. It depends on the reduction in left atrial pressure. More than 2/3 of LA pressure reduced is a good sign of successful PTMC. Some people do mention pressure shoot-up sign, as our picture is in the aorta. And if there is increase in aortic pressure, systolic pressure, it is a good sign. Definitely that input is increased. So the pressure, the aortic pressure is increased. There is echocardiographic assessment, measuring the mitral valve, pressure gradients. We can auscultate regarding the decrease in length or disappearance of diastolic murmur. Again, in the severity of MR is very important, which is a complication which can occur if there is on auscultation there is no systolic murmur, and on echocardiography there is no significant increase in severity of MR. And again, in the cath lab, if we check LV and LA pressure simultaneously to see the change in LV EDB, this is also a great sign of showing if there is any increase in the severity of MR. So these are the signs we have to keep in our mind regarding the success of the PTMC. Complications, few complications are very important. As I mentioned, acute severe MR, need for urgent surgical intervention, pericardial effusion, we need to drain it, we need to do this again. Another important and complication is the stitch puncture. People do talk about it, the stitch puncture and how it happens. This is a very, although it is a rare complication, but it's something not very happily accepted in the cath lab. So this is basically the stitch phenomena. And okay, so if we see that this is the position of interatrial septum, if there is significantly large LA, significantly dilated LA, this LA will build a folding on the RA, and there creates an invagination of the pericardium, and there is a space between LA and RA. In case of a very high puncture, when we are puncturing interatrial septum, it will first go from the LA, then for a free pericardial space here, and then in LA. What happens, we'll complete our procedure very nicely. And it is called as a stitch because during the procedure, it is stitched between the two walls of LA and RA. So after the completion of the procedure, after some time, say after 30 to 40 minutes, few people say it occurs normally, it starts immediately. And after some time, there is signs and symptoms of tamponade. So again, we have to keep in mind the basic landmarks, horizontal M and vertical midline, where we have to keep in mind, especially when there is very large LA. It is also shown on the left side in the schematic diagram as well. Thank you very much.
Excellent talk. Nice practical review of transseptal puncture and PMBV. I think we have a case presentation with practical tips and tricks. Probably we'll have that first and then have a panelist discussion on the approach. So are we ready for the talk? For the case presentation? While he's setting it up, Dr. Ramzan, I was interested in terms of whether you use transseptal echocardiography for guidance with transseptal puncture. Dr. Badar or any of the panelists, because it's very helpful. You can be very precise exactly where you're going, by just having three views. If you have a short axis view looking at the aorta, you can confirm your anterior and posterior position. In your bicable view, you can look at the superior and inferior position. In your four-chamber view, you can look at the height in relation to the mitral valve. So especially now with the left atrial appendage closure and mitral clip, you want to be more precise about the puncture site where you're entering, and it's more helpful. So, for our PTMCs, we're not using the T's. If any comments from the panelists or the speaker, that'll be great. Dr. Badar, any thoughts on why T is not being used routinely? Or
sorry, can you repeat your question?
I guess I can bring it. I was asking about the role of TEE and transseptal puncture. Can we help you be very precise? So we don't see it being used in Pakistan very often. In US, we use it routinely for transseptal punctures. So just wanted your thoughts on that. I guess we are ready for a presentation. Dr. Mohammed Ramzan, you ready to go?
Yes, I'm ready. Assalamu alaikum. Can you hear me clearly?
All right, then let's get started. We'll have a further discussion at the end.
Hello, can you listen?
Yes, we can listen. You can start.
My screen is visible to you all.
Yes, they are visible. You can get started.
Thank you very much, Professor Nauman Naseer and Pakistan Society of Interventional Cardiology, all the panelists and the attendees. Good morning from Bhutan. I am Dr. Ramzan, working as Assistant Professor of Cardiology here. And as Dr. Badar has in detail and clearly mentioned all the techniques and tips and tricks of the septal puncture and the PTMC. So this procedure is being done quite frequently at our center, about 8 to 12 cases per week. And I will share a case with you all. We done around 4 or 5 days before in our center. And this is a young lady. Okay, sir. This is the young lady of 25 years age. She presented at our center with the history of dyspnea on exertion. Her pulse was 80 beats per minute, which was regular, and her blood pressure was 110 by 70 millimeter of mercury. On the auscultation of the precordium, the first heart sound was loud, and the pulmonic component of the second heart sound was also loud. And there was a mid-diastolic murmur audible at the apex. So she was having diagnosed as a case of severe mitral stenosis and moderate pulmonary hypertension due to rheumatic heart disease. We performed her transthoracic echo, and as you can clearly see that the mitral valve is rheumatic and it's thickened with restricted movements, and it is severely sinuous apart from the dilated LA and prominent coronary sinus. On the color Doppler interrogation, there is a trace of mild eccentric mitral regurgitation, and there is no other valve lesions. So we did her a planimetry of the mitral valve in the short axis, and it was 0.9 centimeters square, which is clearly showing that the valve is severely stenosed. So pulmonary hypertension is moderate with TVPG is around 57 millimeter of mercury. This is the apical two-chamber view, which is showing mild eccentric MR. We did have Wilkins scoring, and that was 8 by 16, which was quite fine for this procedure. On the day of the procedure, we do the transesophageal echo of this patient before the PTMC procedure. There was a dense echo contrast in the left atrium and the left atrial appendage, but there was no definite clot in the LA or in the appendage. This is the bicaval view on the transesophageal. You can clearly see the septum, the thickest part all around, but the fossa vellus is the thinnest part in this view. 120 view, the color Doppler interrogation, no much mitral regurgitation, and the valve is severely stenosed. These are the gradients of the mitral valve. Mean gradient is around 23.5. So we in the cath lab, we first of all we took the axis on the right femoral vein and the artery. Femoral vein axis we took slightly lower than the arterial one, so that we can negotiate all the instruments which will be passing through this axis side. So this is the toolkit, as Dr. Badar has already mentioned, that at our center we usually puncture the left interatrial septum with the help of broken row and the puncture needle. We don't use frequently the Mullen sheet, so our assembly only consists of the broken row and the puncture needle. Puncture needle is about 4 centimeters longer than the broken row. Broken row is 67 and the puncture needle is 70. That's why when we puncture, the needle comes out of the broken row. And apart from this, the O2-5 guide wire, pigtail, and the multi-purpose catheter. So this is the puncture needle. as we can see, the distal part of the puncture needle is 21 gauge and the proximal part is 18 gauge. And there is an arrow on the proximal part which will guide us that in which clock position we are in different views. And from this, we can navigate the needle so that to get a proper site for the septal puncture. So after getting the access, we place a multipurpose catheter in the left innominate vein, and we give a slight injection to show this innominate vein. And the pigtail is lying in the non-chronic cusp of the aortic valve. I will show you the landmarks I have just marked in this video, and Dr. Badar has already shown these landmarks. By modified hung fluoroscopic method, even without the contrast, we can use the LA shadow and the pigtail to mark the vertical midline. So we will take a point from the pigtail, that is the non-chronic cusp of the aorta, to the outer border of the LA, and then we will draw a vertical line from this, the midpoint of this horizontal line, and this will be our midline. And this midline is usually passes through the middle of the septum, interatrial septum. The second step is we will perform the LV angiogram with the help of the pigtail in the RAO30 view, and by this view we will mark the horizontal M line. As I have marked in this, you can clearly see that we will first we will draw a line from the from this mitral annulus across the mitral annulus, and from the midpoint of this mitral annulus line, we will draw a horizontal line towards the spine, and this will delineate the spine, which in this case it was the T10 vertebra. And this horizontal M line basically is passing through the middle of the mitral valve. So our puncture point, the ideal puncture site is the intersection point of the midline and the vertical midline and the horizontal M line. And this usually in the frontal view or the AP view, it is usually half to one vertebral space below the horizontal plane of the tip of the aortic root. So we took our assembly consisting of the puncture needle and the broken row from the left innominate vein, and you can well appreciate the descent from the SVC into RA, the first movement or the first jump, which is clearly being appreciated even in this view. And the second jump is from right atrium to the fossa ovalis. Usually this jump is subtle, so not being clearly, appreciated. And some author also mentioned the third jump, which is from the RA across the aortic root. After placing the our assembly most likely in the fossa ovalis, we will confirm this in the RA view. As you can see on the right side, the different landmarks of the RA view, the fossa ovalis is clearly been shown that is directed posteriorly, and it is away from the pigtail. So our assembly should be directed posteriorly, and it should be away from the pigtail. Only then we can say that we can safely perform the puncture. This is the lateral view of this patient, and here the landmarks I have delineate with this between it should our assembly should be between the spine and the pigtail, and it should be directed away from the pigtail and posteriorly directed. So after confirmation, I did the puncture with the puncture needle, and I we confirm it with giving some contrast in this lateral view. Then I bring change the view to the frontal view, again confirming that we are in the left atrium. And after confirmation, I did the LA angiogram. You can see the LA appendage, LA, and this view is also important to mark the site of the mitral valve, where the mitral valve lies, so that in next step, when we will be crossing the mitral valve with the Inouye balloon, we should use this view as a roadmap. Then after puncturing the left atrium, we took the pressures of the left atrium and the left ventricle with the help of pigtail and the broken brow simultaneously. And we can clearly see that the pressures are significantly, diastolic pressures are significantly increased, and the mean LA pressure is 32. Now, at this time, moment, we will give the heparin to the patient, and usually our routine is 100 units per kg. We give the heparin to the patient. After septal puncture, then we will start preparing the balloon for the mitral valvotomy, and this is the whole assembly of the PTMC toolkit. There is a ruler, there is a 14F dilator for the septal dilatation, and there is a balloon stretching tube, the spring stylus, and there is a LA guide wire, and then there is an Inouye balloon and the inflation syringe. Our patient has a height of 160 centimeter. So as per the formula of the height divided by 10 and by plus 10, so the balloon size was 26 centimeters. So we took on our patient the Touré 26 centimeter size balloon. So these are the different parts of the balloon, and Dr. Badar has clearly, detailed described the proximal part, the different distal part, and how the distal part has 3 components and how they are sequentially being dilated. So we took the LA guide wire and we passed it through the broken brow into the LA and looped it in the LA. And after this, this is the beautiful crossing of the our balloon into the LA over the LA wire. After this, we took the LA wire and put the spring stylus to redirect the balloon across the mitral valve. This is the AP view, and then we will move into the RAO view, where we can clearly see the bobbing movements of the balloon across the over the mitral valve, where we are going to cross this. So by just when we are on the mitral valve, we will just pull the spring stylus and push the balloon softly, and it will go into the apex of the LV. And we can clearly see in our patient. After this, these are the 3 sequential methods. How we inflate the balloon. First of all, we just dilate the, we inflate the distal part of the balloon and just pull the balloon across the mitral valve. And the second step is to inflate the proximal part, and in the last, the thickest part of the balloon, which is the sleeve in between the 2 balloon, 2 parts, that will be inflated after more inflation with the same syringe. And we can clearly see that the beautifully the anterolateral commissure has been splitted, and the posteromedial commissure has been split in this case. Well, we took the post-PTMC parameters on the table, and the left atrial pressure was reduced more than 50%. On auscultation, there was no systolic murmur, and when we did the bedside echo, table echo of this patient, there was no pericardial effusion, and there was only mild MR. So our procedure was successfully completed. On the next day, I did the echo, transthoracic echo of this patient. Now we can easily appreciate that the mitral valve is nicely opening. And color Doppler interrogation is showing just mild MR, the same as it was pre-PTMC. And apical 4-chamber view, again that MR is being shown. And when we did the planimetry of the aortic valve, the area was around 1.9 to 2 centimeters. So our procedure was successfully done. Pressure of time is also showing the area of 1.9 centimeters square. So this is our team. Thank you very much for the patience listening to you all.
Thank you, Dr. Ramzan. Excellent step-by-step presentation, and both Dr. Badar and Dr. Ramzan put up an excellent show. I really loved the talks. So now we'll head over to the panelists for comments. And I guess Professor Tariq Abbas, are you ready? Do you have any? Yeah, you're right. Yes, together. So your thoughts and comments on the case presented and just from your center, I believe you do a lot of this and nice presentation there.
Thank you, Nauman, and thank you everybody listening us from Multan Institute of Cardiology. Basically, PTMC has a long learning curve and very steep learning curve, and it is not a procedure of West. Now it become procedure of East and our part of the world, and it's the one procedure that people are traveling from United States to our centers to learn this, how to do the septal puncture and how to cross the mitral valve. And definitely in our region, Pakistan, India, and Bangladesh, we have more experience in these kind of procedures. We are holding a regular workshop with the collaboration of University of Virginia in start of the year, and we are doing 20-30 cases in 2-3 days of these septal punctures with the under transesophageal guidance and other things. But definitely our residents has got to learn these techniques. It's a very different and difficult procedure. Basically, lot of steps you have to learn, and you have to be very calm and cool by learning that. Different centers using different techniques. As we are trained in an air balloon, and we are doing all this procedure through an air balloon, we don't have experience with biotome. We don't have experience with the double balloon techniques. Definitely, people from Karachi and people from Lahore, as our mentor is here, Professor Zubair Saab, we learn all these techniques from Professor Zubair Saab and Punjab Institute of Cardiology. They will be better to tell us about the other techniques also that we are using in Karachi and Lahore and Islamabad. Thank you very much.
Thank you. Professor Zubair Akram Sahab, I believe you've joined us. So your thoughts on the PMBV technique, and the talks that was just presented. Thank you for joining us.
Thank you, Nauman. Wonderful. You have been. We are so proud of you. And talking of and very good talks by Badar, and then Ramzan showed a very good case. History for me. PTMC dates back for us in Pakistan dates back to about 20. Institute of Cardiology do the the cardiac heart disease is declining. As Sohail must be remember, we had so much of cases early 90s that even in this century as well, but still incidences.
Having a connection with your voice, Zubair Saab.
Nauman Saab, if I could make a comment.
Yes, please. I was coming to you next. Zubair Saab abhi comment de rahe the apna. Zubair bhai, aapki awaaz nahi aa rahi. Professor Zubair, we can't hear you, Professor Zubair.
I have.
Now we can hear you. Now we can hear you. You were muted, I guess.
When Inouye come to us in Pakistan in mid 90s, I like. Listen me. Can you listen me, Nauman?
No, now we can hear you. You just lose your voice intermittently. Yes.
Yes, when we did, when we started 90s, Mr. Inouye himself, PSIC, and the was to start with the RV angiogram, and then he would LA phase, and then he would pick start with this. The techniques have, the years, so it has become much more safer. I would tips and tricks, most important is the patient. And, we have talked about Wilkins scores and commission scores, etc. For me, the commission score is very important. And I all focus with commissions, Sometimes, on AP view, just find very thin leaflets and very thick leaflets. But when you look at the short axis view, the commissions are fused, leaflets are morphology. The punctate for me is also a high risk morphology. I always focus on short axis view to decide. The second thing, for the PTMC patient is which rhythm the patient is, the presenters have not focused, maybe the patients they were in sinus rhythm. For me, the patient with atrial fibrillation, especially if it's atrial fibrillation, is always a challenge, First of all, we go ahead to slow down the rate. Think transesophageal echocardiography is mandatory to go for, and patient needs PTMC, and if there is a LA appendage, obviously, people will say, some people make anticoagulate the patient, bring the patient back for transesophageal after 4 to 6 weeks or 3 months, and if the LA appendage clot has gone, obviously then it's there. Then the Wilkins score, that is most important for me. We always see that this is a very good case, suitable case for PTMC. This is a borderline suitable case, and this is a high risk case for PTMC, So we always, after the patient selection, for high risk case, first of all, special, and somehow or another, we need a surgical backup also. So that if we land up with a severe MR post PTMC, the surgeon should be available, because it needs to be fixed there and then. Regarding the puncture techniques, obviously, Dr. Badar has showed so many techniques, but important for me the lateral part. You stay septum, you puncture it immediately after that, you do injection, you are in that, what Innoit taught immediately after that you are in, you always give 1,000 children, a normal practice, still I use this, this, that some this now the balloon puncture is okay, you are able nicely, some higher puncture, this,
what your voice is breaking up again. Your voice is
way back. Can you listen to me? You listen to me?
Yeah, it was there. Now the connection is picking up again. It's just on and off now. But thank you very much, Zubair, for your comments. I mean, from a lot of the tips that you mentioned, patient selection, along with watching out for commissural calcification, those things are very important. And if I can head over to Sohail Saab, can you share your thoughts? So you've done a lot of PMBs as well. And
thank you, Dr. Nauman. It's been a wonderful session, great cases being presented. I think we, Zubair Saab, and different places started off together with Innoy and TRD Shaw and Igor Palacio, all coming to our centers. That's how we learned with, but we had the advantage of a lot of volume, and we would reuse equipment in those days. So each list would have 6 to 8 cases of PTMCs, and it's not difficult to select 6-8 cases. I think I need to share just a few thoughts, despite the wonderful lectures being presented, that the calcification in mitral leaflet is important in determining the pliability and whether you can safely open this or not. So if you have calcium in the 3 and 9 o'clock, that is not going to be suitable for ballooning, because you're going to split across it and tear the valve. So that's important, that the site of calcium is more important than the amount of calcium, as far as we're concerned. And in order to find the exact puncture spot, we've got different ways of doing it. And Noah had another way of doing it. He would use a levo phase. Levo phase was when you injected into the RA, and then you waited a few seconds and took another picture, and you'd get the LA. And you try to find out the overlap point with this formula, which is pretty common. And in fact, our first few hundred cases were always this levo phase, and we would then puncture, and that was pretty accurate. And then we had Alain Cribier, who came with his Cribier device, which is a basically metal mesurotome. For that, you had to do a low puncture, and you had to go too lateral in order to confirm your LA position, which I think in a difficult puncture, too lateral is a very important position for me. Then I think in sizing, we have all used heights as a measure, but I've worked with a lot of pediatric guys, and since then I've worked out this formula that the mitral valve annulus comes in very handy. So when you're assessing your PTMC, mitral valve PTMC, you must measure the annulus size, and that tells you what is the maximum size of balloon you can give. I mean, I was in a workshop where the size determined was 26 millimeter, whereas they ended up ballooning with a 30 millimeter. And, so they use an annulus size to work out what is the maximum size of the balloon which can happen. A word about the stitch puncture. That tends to happen normally when you do a septal puncture, you come from above. Sometimes if you fall down and you're a bit too lazy to put the wire back in and take it the puncture needle up again, you try and puncture from below. So you try and puncture going up. That's when you get the stitch puncture. So that's something which you must always be very careful about. And the TRD Shaw's maneuver of the step ladder, which we've talked about, he actually to us defined that step ladder was a way of going up. When you pointed the puncture needle literally and moved it left and right, and you pushed it up, that to him was the step ladder. I think there's another maneuver which we have started doing, is that when we inflate the mitral balloon distally, we also start injecting dye in the pigtail. So when you start injecting dye in the pigtail, the whole LV and mitral valve is very clearly delineated. And so you cannot miss or inflate the annoy subvalvular. So you can clearly see where it is. I'll try and show you a few clips of what we do it. We do it quite regularly. That comes in handy. I think there are other things which we can talk about. Another is that we apply a dye contrast on the puncture needle. So once we puncture the needle, lots of people you have seen stain the septum, which is a good thing. You know where the septum is. So once you puncture, you give a little puff of dye and you can see the back wall of the left atrium. And that comes in handy in knowing that you have punctured properly. One more thing, there's so many points, but one more thing is that if for some reason you inject and you find that you are in the aorta, don't pull the equipment back, because that equipment is now plugging that hole. And if you pull it the thing back, you can actually start creating a real big jet from the aorta into the RA, and which can be hemodynamically very compromising. The patient can collapse. We in fact had a case where we punctured into the aorta, and then we called up PEDS guys over, and they put a small, they exchanged it with a wire, and they put a small VST closure device. That sealed the puncture, and we saved from surgery. So if you somehow think that your needle has, and needle doesn't really matter, but if your dilator has gone into some other place, then you should not pull it back. You should leave it there and let the surgeons take over. I think it's been a great session, wonderful.
That was a very important point, Sohail, regarding the complications and the tips regarding the procedure, that if you have punctured the aorta, needle is okay, but if anything more than that, leave it in and have the surgeon follow up. And that was a nice case that you shared, that you used a VSD closure device to seal that puncture. Since we're running out of time, I'll just go over to the other panelists for just a brief comments, a minute or so. Professor Tariq Ashraf has joined us as well. You wanted to share a book as well that you feel is very useful for the fellows, Professor Tariq Ashraf?
Yeah, I think it's very important now. You can see this book. It's about percutaneous mitral valvotomy. and it's been written by Hari Krishan. 3 of the articles from Pakistan were been cited in this book. 2 of mine regarding multi-track balloon catheter, what we used in NSAVD when I was at NSAVD, and 1 from Professor Hafizullah about septal puncture. And it contains 1 CD also. It contains all the steps and anatomy and everything a post fellow or a fellow wants to learn. If you want to have this book, you can request it to Farmigo Company, and they will provide you the book as well as the CD. And I think everyone should read it. Even I usually read this book, and it's more informative and quite learning for everyone. Thank you.
Great, thank you. That seems to be a great resource. Professor Habizullah Sabi, they mentioned your article in that book, and you've trained a lot of people in PMBV as well, and you're there. I just saw you. Your thoughts? I had a question. I don't know if you were able to hear before. You know, we were talking about the precision of entering the septum. In US, we are using transseptal echocardiogram, you know, for most procedures now, and you know exactly where you're entering. So all this guesswork goes away. 3 views you need, you know, short axis, which can tell you anterior and posterior, bicable, which can tell you superior, inferior, and then you have the 4-chamber view, which can tell you the height in relation to the mitral valve. So my question now to all the panelists, and you're all doing routinely PMVs over here, is that why are we not doing TEE in these procedures that will just make it more safer, more precise in terms of where you're entering, and you have more control of the procedure? I mean, it may increase time and you need more logistics-wise, another person doing a TE and general anesthesia and all that. So thoughts on that, Professor Habizullah Saab? I know you were one of the, you know,
Right. Assalamu alaikum. Thanks for giving me an opportunity. We started our PTMC program, and this is one of the good results that we have out of the cardiology conference that we held in 1991. We had a gentleman by the name of Dr. Stanton Perry. We had invited specifically from Harvard, and he taught us at that time the technique of transseptal puncture, and at that time there was no dedicated balloon, so we used to go in the septum, through the septum, dilate that septum with a specific balloon of 3 or 4 millimeter, and then we would use Swan-Ganz catheter to advance into LV, and we put 1 guide wire, then we'll put another guide wire, and we will use 2 balloons technique at that time. And then after a couple of years came Inouye balloon, and then I published the data, the difference between Inouye balloon versus 2 balloons. And that was very interesting to see that Inouye balloon would definitely give you better result. It was safer as well, and there was nothing to puncture left ventricle. 1. Second, we looked at our data of mitral valve, and though we say that it is critical after 1 centimeter square, I proved through the echocardiographic data that even below 1.5, you know, the LA starts dilating and the pulmonary artery pressure gets building up. So in most cases, we should be looking at that 1.5 and below is something severe MS, and we should treat it like this. Third innovation that we did was that we were able to enter into the LA without actually puncturing. So we will be able to cross the fossa ovalis. And then we train most of our fellows, and in 80% of times, we are able to cross from RA to LA through fossa ovalis. And that's perhaps is the best thing, because that gives you a very nice angle to enter into left atrium to left ventricle. And Inouye balloon has given us excellent results. We have had then re-PTMC. I've done 4 PTMCs in one lady, and I think the first one was done at 12 years of age, second 16, then 21 and 25. And there are many patients with 2 PTMCs. There are certain patients who get excellent result with a PTMC, like we get area of 1.7, 1.8, and others re-stenose. This is more like an ISR that we get in coronary arteries. We cannot prognosticate who will develop ISR and who will not. So these 3 comments. And sorry, your point about TEE, I think when we started at that time, Peshawar did have TEE, but I mean, we considered to be putting patient into more hassle. And by and large, we got so used to it that even our senior registrars and I think Dr. Adnan Gul did lots and lots of PTMCs and published. We have probably the most published department in Pakistan. Thank you.
Thank you. Now, I think we have a last minute to go, and we'll get closing remarks from Nadeem Rizvi Saab, our president. I see him sitting over as well. And
thank you, and thank you, Nauman. Excellent presentation. I just wanted a quick input from my other panelists, because you are all experts regarding reuse of INOE balloon. You know, I just we are getting towards that area where this is going to be a problem. If you are now with the Sehat card, and an angioplasty can cost 1,77,000 or 180, and even 230, 240 with two. What is the justification now of reusing INOE balloon? Because now on the Sehat card, I think we should be going towards everything new. What are your comments about that? Because it's going to be very difficult justifying reusing this equipment.
I think in Sehat card, we can
if I could
now,
make comment.
we can use the new one. The only problem is that INOE balloon, which used to cost around 120, now it costs about 270. So the whole package is around 270. It has become atrociously expensive. We used to use it up till 4 times. Now, unfortunately, the quality of balloon is not good. So in Sehat card, now we can use a new balloon and they pay for it. That's not a problem.
That's good to know. Last question and last minute, 1 minute.
Sorry, Nauman.
I had a question from Dr. Shabazz Server. Would someone highlight the criterion of successful PTMC? So when you're doing it, when do you know when to stop? So last question, any panelists, if they can answer, just 1 minute answer, please.
I think when the waist disappears altogether, one. Secondly, the balloon voluntarily, not willingly, voluntarily jumps from the position to LA. So when the balloon jumps back into LA and the waist totally disappears, you know that you've done a good job.
Yeah. Thank you. On that note, we'll end. Sohail Saab, you wanted to say something?
I think the severity is 1 centimeter per body surface area in meters. So for an average guy, 1.5 is considered severe. And so either you double it or you reach 1.2 millimeter. The valve area either has to double or it has to, go beyond 1.8 or 9. So that's a successful procedure. But a word about reuse. I think if we reuse any equipment, the implication, if any, will come on the operator and the hospital. And we'll be saving costs for different people. So I think we should not let this reuse gambit play on the cardiologist and take onus for reuse and saving money and trying to think we're doing good. The society needs to pull up and get the money going, and they should have a special rate for PTMC. We should just not reuse equipment. I would insist we should reuse guidelines as determined by the countries overseas, which is anything which has a lumen cannot be reused. So if it doesn't have a lumen, it can be reused, but if it has a lumen, it cannot be. It is just too chancy in today's day and age because of scandals going around to have reuse of equipment. So that's my take for what Nadeem said about. And a word about esophageal, transesophageal punctures. You see, when you do particular punctures as in mitral clip or LA occlusion, you need to have different site of punctures. For that, T is very essential. But on an average, if you're a very good expert, you can do. But for T, either you have to give a GA, general anesthesia, because the T cannot be well tolerated while if it takes a little longer to puncture. But I think the EP guy have their own way of puncturing. So if for tricky, very large LAs or where you have difficulty puncture, you must have a T probe ready for a safe puncture. And I think, like Nauman, you said, safety is very important. And as the procedures are progressing, world progressing, these devices are available, we must use a T And I would suggest to my colleagues, those who have tea available, that you use it every now and then for these punches also. It'll just improve your skills also.
Thank you. Very useful comments by General Sohail and everyone in the panelists. Really appreciate your joining. Excellent session. I loved it, and I hope everyone else also did. So on that note, we'll end until next time, last Saturday.
One more thing, Nauman. We did not advertise the session well. Very few people are here because nobody seems to have link. So I think we need to find a way of advertising these sessions a little better.
We'll try to advertise it further. We had about 45 to 15 in attendance online, and 20 to 30 physical in attendance from what I heard. So about a total of 70 to 80, but less than what we have had in the past, 90 to 100 online and 20 30 so physically. Did advertise in the master's group and some of the fellows group, but we'll try to spread it out further. Thank you everyone for joining. Take care. Have a nice week.
Thank you very much.